I'm a licensed clinical psychologist in Naperville with a private practice and a tenured associate professor at DePaul University. And I want to share 4 issues with you that concern my patients that would likely be impacted by House Bill 311. Specifically, coordination of benefits, self-funded insurance plans, workers' compensation payments, temporary residents and employees who work for companies headquartered out of state, and the inappropriateness of distinguishing severe mental illness from other kinds of mental illness. Let me illustrate this very simply with a few cases. The names have been changed, but the essential facts represent real people with real situations here represented. First, consider Ralph. Ralph developed chest pain during a routine treadmill stress test. He needed surgery immediately, and he was rushed to the emergency room for a coronary artery bypass graft. And following the surgery, Ralph developed severe symptoms of depression. He decompensated, he became disoriented, went into a dissociative fugue state. He was acutely suicidal and believed that he'd lost his family and his profession. He quickly ran out of mental health benefits that would have helped his recovery, despite the fact that he thought that with depression, his employer, in fact, would provide coverage under the parity laws of the under the Insurance Act here. Now, a so-called insurance company, which was managed by an organization that looked like an insurance company, refused to pay, citing that they weren't required to pay for mental health coverage because they were a self-insured plan, and they were exempt from mental health parity laws. That's a coverage requirement under the Illinois Insurance Act. Ralph wasn't able to get the kind of treatment that he needed to support a successful rehabilitation and return to work. His medical and psychiatric conditions deteriorated because of a lack of availability of affordable health care. And as a result, this person was left totally and permanently disabled due to his depression and the things that resulted as a result of that. Society is going to be denied Ralph's professional services, and he will be supported by other social systems of disability financing, probably for the rest of his life. House Bill 311, if passed, I would hope would allow this person to have access to real health care when he needed it, whether it was physical health or mental health care. Jane was a registered nurse, and she was injured while saving a hospitalized patient from falling. She had significant structural damage to her neck, shoulders, and spine. Now, Jane was living pretty much as a hand-to-mouth single mom trying to raise a teenage son. And when she could no longer work because of her injuries, she depended on workers' compensation to provide medical coverage for her work-related accident. Jane was referred to me for depression that resulted as a result of that accident, and she encountered resistance to providing mental health coverage or to obtaining it because her employer said this was a physical injury, it was not a mental injury, and mental health should not be impacted. Treatment for her mental conditions, her depression that resulted from the accident, was denied. Eventually, she was able to get services through me, but we had to get one session authorized at a time, and it often took weeks and weeks to obtain authorization to do yet one more treatment session. A single system payer of medical coverage would have enabled Jane to access treatment without delays in determining who it is that should pay. I don't know how this might impact workers' compensation, but the first thing that Jane needed was medical treatment and medical coverage, and that was simply unavailable to her while people figured out who was going to ultimately be responsible for compensation. Now, the scope of who would be covered by House Bill 311, the way I read it, is certainly very broad and appropriately so. And several times a year, I have people that I'm treating that have maxed out their available mental health benefits. Even when people have serious mental illness, is defined by the Illinois Insurance Act, that includes things like bipolar disorder and schizophrenia and major depression, are often denied parity benefits because their company is headquartered outside of the state of Illinois. As the company that's headquartered outside of the state of Illinois, Illinois residents then are exempt, or the company is exempt from providing mental health care under the Illinois Insurance Act. Or if the health care policy is written by an insurance company outside the state of Illinois, they also claim then that they would be exempt from simple parity coverage, even for severe mental illnesses. And I hope that House Bill 311 will indeed firmly address those kinds of issues, Representative. House Bill 311 makes a special provision for ongoing mental health and counseling services outside the hospital for patients with serious mental illness. That's done in Section 50 of that bill. And this is really unnecessary, it's redundant, and may be interpreted as exclusionary for persons with mental illness that doesn't fall under this serious banner. Let me just share with you some of the burden that these folks have to deal with, and the burden on our healthcare system for not providing adequate coverage for this group. These are folks with diminished educational experiences, and they're unable to take part in the full range of opportunities. Relationships are impaired. These are folks who don't initiate relationships with other people. For relationships that they have, they don't often nurture those very well. When people are in relationship, those relationships get damaged. And people with social phobia often don't have the skills to be able to repair that kind of damage. Depression is a constant companion to those with social phobia, but it's rarely diagnosed as depression. It's just something that's there. Alcohol and substance abuse is also quite common. In fact, it's rampant in that group. One comorbidity study of substance abuse and social phobia suggested that in 85% of the cases of alcoholics, social phobia was also present. And the social phobia preceded the alcoholism. Lifetime suicide attempts for people with social phobia are actually higher than they are for people with diagnosed major depression. Healthcare utilization is about 25% higher for people with social phobia than it is for the general population. Work hours missed due to health concerns is more than double that of the general population of people with social phobia. And average wages are lower, college graduation rates are lower, and the proportion of people seeking professional or managerial jobs is also much lower. The burden on society is very, very high for someone who has a condition that can be helped, who needs access to mental health services that are currently denied by many insurance programs, or they're limited by insurance programs, and for those who need more than their 20 sessions a year that might be covered by an employer, they're simply out of luck. They don't have routine access. I hope that this illustrates some issues. There are issues about coordination of benefits with workers' compensation, problems with self-funded plans, problems with workers' compensation itself, and the inappropriateness sometimes of distinguishing severe mental illness from other kinds of mental illness. And I hope that this testimony will help you decide how to go forward and shore up whatever it is that needs to be done and carry the message back to Springfield that mental health parity is needed and the impact is on all of healthcare. Thank you.
Thank you, Dr.